Hi, everyone. My name is Van Top Park, and I am a professor at UCSF, Department of Community Health Systems. I am delighted to be here to talk about the importance and lessons learned with meaningful engagement of Asian American, Native Hawaiian, and Pacific Islander communities in ADRD research. First, I would like to thank Dr. Morris and the Knight ADRC for inviting me to give this presentation. I wish I could be there with you, but due to personal family matters that I have to attend to, I am unable to travel to be in person at the conference. I'm going to provide a little bit of background and talk a lot about the CARE registry, as well as the Asian Cohort for Alzheimer's Disease Study, ACAD. Another project, it's a PCORI dissemination community engagement project called Kimchi. Koreans invested in making caregivers' health important. And briefly mention ARISE, Asian Americans and Racism, Individual and Structural Experiences, and this will be a new cohort study. Unfortunately, I cannot take Q&A due to the recording nature of this presentation, but do feel free to reach out to me if you have any questions, and I'm also happy to schedule a meeting with you if you are interested. First, briefly, who are AA and HPI communities or populations? Asian Americans are the fastest growing racial group in the US, comprising nearly 8% of the US population. ANHPI populations are heterogeneous and in nature, and there are many languages and dialects, cultural groups, immigration patterns, religions, diets, and social economic status. You can see here on the right of the screen the proportion of those who have limited English proficiency. And you can see the diversity in this. And this certainly is important to realize and understand as we do outreach with diversity in HPI communities, especially those who are older adults. As we all know, older adults tend to have even higher proportions of LEP, limited English proficiency. Many of you are probably familiar with the model minority myth. This was the model minority was coined in the 60s, and it was really a way to, unfortunately, share the quote unquote success of Japanese Americans during that time. And it created this notion, which continues to be perpetuated, that ANHPI individuals, because all ANHPI are the quote unquote the same, right? Obviously, I don't agree with that, and many of us don't. But that ANHPI individuals are doing just fine, are doing well, if not better, than non-Hispanic whites, and do not need assistance, do not need resources, you know, all those kinds of related things, and that discrimination against racial ethnic minorities is non-existent. And unfortunately, the model minority is a notion or this myth that continues to exist everywhere in society at a conscious level and subconscious level, and directly and indirectly plays into the fact that there is a serious underrepresentation of AA and HBI populations in research, including ADRD research. Many of you might be familiar with this statistic, but a research study by Duan and colleagues that was published in 2019, they looked at what has been supported or funded by the NIH in the past 25 plus years. And what they found was that 0.17%, so not even a percent, unfortunately, of the NIH budget went to support clinical research projects that targeted ANHPI populations. And I don't think I need to go further about how sad that statistic is and how we need to make meaningful change in this area. And many of you are also aware that less than 3% of the participants in ADRC research studies are ANHPI, and many of whom I would suspect who are participating or have participated in ADRC sponsored or supported research are likely to be proficient in English and high SES. There are many challenges to participation in research for NHPI communities. One thing I share often in formal settings and informal settings is I do ask the question to researchers, including those who reach out to me and my colleagues, I think, about the hopes of improving representation from NHPI communities. It's one thing is that there's not one way to conduct outreach and get the outcomes that we all hope for, i.e., increased representation or successful research participation among ANHPI, especially older adults, in ADRD research. The main thing we have to do is really abide by the community-based participatory research model and community-engaged research principles as well, and identify the community stakeholders, work very closely with them, and listen and be present, and show up, continue the dialogue, continue the learnings together. One thing we have to bear in mind as we develop our budgets, our research study designs, etc., is that we need to adequately budget for bicultural, bilingual staff and budget for community partners. And if we do those things, and then we get the next step to develop the culturally and linguistically appropriate outreach materials, then we can likely optimize or improve our chances of being able to successfully reach out to diverse ANHPI communities to participate in research, including ADRD research. One thing I share a lot also is I do ask the question when I see research articles or other kinds of public dissemination documents and materials. I question what the researchers have done meaningfully to engage with ANHPI communities. Oftentimes I hear the word that the ANHPI communities are a hard to reach population. What have they done? What have we done? Are they really hard to reach, or did we not do what we should have done, which is from the beginning, identify the relevant and important stakeholders in the community partners, organizations, churches, temples, traditional media, ethnic media, etc., and really ask the important questions that we have. Ask how we can, develop the recruitment messages and what are the good and effective recruitment approaches, etc. And we also have to convey the messages to community partners, not just the community at large. What is ADRD? What is research? And why is it important for us to be at the table? So these are things that I encourage the audience and everyone else to really think about carefully. I'm sure these are things that many of you have heard of already, which certainly applies to NHPI communities as well. So in the remaining 10 minutes or 20 minutes or less that I have, I will briefly introduce some of the various research studies that I am involved in currently. And if you, again, have any questions, do feel free to reach out to me in email, and I'm happy to answer the questions or schedule time to meet with you. So, the care registry, we were fortunate enough to have received a new grant, and Dr. Josh Grill and Dr. Janice So are now MPIs with me in this next adventure with CARE. So CARE was originally funded through an R24, and it's now funded through an R1. It was launched during the pandemic, October 2020. Our goals of CARE is to address the gap and reduce disparities in research participation in ADRD, aging, caregiving, and other health issues across the lifespan for ANHPI populations, and to give our communities a voice and opportunity to participate in research. We implement culturally appropriate innovative recruitment strategies in collaboration with CARE's community partners to enroll ANHPI adults. So the eligibility criteria for CARE is quite simple. You have to self-identify as ANHPI, be an adult, and the reason why 18 years is the minimum or is the threshold for age is because many ANHPI families live in intergenerational households or have very tight family units, community units, etc., and are caregivers to older adults. As of now, we have our enrollment survey in English, Chinese, Hindi, Korean, Vietnamese, and Samoan. However, with CARE 2.0, we do hope to be able to add additional languages, and the identification of such languages will be in consultation, of course, with our community partners. The participants can enroll in CARE online or by phone or in person, and we ask questions related to their sociodemographics, health conditions, health behaviors, and caregiver experiences. And these questions or items in the survey are meant to be helpful in the referral process. In other words, when researchers are interested in utilizing the registry as a recruitment source for their own studies, we do our best to identify the sample or the subsample population of the registry that could potentially fit their eligibility criteria. Obviously, they need to do their own set of work, doing the screening, etc., to determine eligibility and do informed consent. But these are why we have these kinds of questions. Just a snapshot, we have enrolled more than 10,000. We put a pause on active recruitment during the phase, a few months in between of funding sources. And as we gear up for CARE 2.0, we anticipate and hope that the active recruitment will begin next year. One thing I want to point out, and I'm sure you'll have access to the PowerPoint slides here, but the important thing I want to mention is the large proportion or high proportion of those who were born outside the US. CARE started off really as a California-based registry, and with CARE 2.0, we hope that we can expand it with targeted efforts outside California from American Samoa to Hawaii and Texas, etc. One very important statistic to note is that more than 80% of our participants have never participated in research. And the fact that they are now willing to be contacted about potential research is really a big deal. Now, does this mean that they're suddenly ready to consent to providing blood or participating in intervention study? That's for many of them, that's to be determined, and that's also dependent on the engagement effort of the researcher and how they reach out to our registry participants. without going too much into it due to time constraints, the care staff can work closely with the researchers interested in using care as a recruitment source on um, best ways to outreach to our care participants. Just wanted to provide examples of retention efforts that we have, which were at a basic level, I would say, for the R24, the 3-year grant. And we have created executive summary reports every year and shared this with our participants and stakeholders. We've also developed a 10,000 participant celebrities video. Please do check it out. And we have multilingual e-newsletter that we provide to our participants. We've done a number of outreach events targeting community members, researchers, or both. Many of these have been conducted in English, but also many have been conducted in the other languages you see here. In terms of care-supported recruitment requests, we have received about 90 so far. And since January 2021, when we made it available and started advertising care to the research community, more than 9,000 care participants have been referred to 57 studies. 29 of the requesting studies have study materials or personnel support for participants in English and at least one other NHPI language. You can see here that these studies have been funded a lot by the NIH and as well as the Alzheimer Association and other kinds of funding sources as well. Many of these studies are focused on ADRD or other caregiving, but also we have other studies that are different that focus in other health topics, and we welcome those studies as well, because any kind of opportunity for our registry participants would be one step closer to actual research participation, and that's really our goal. We have conducted brain trust meetings that provide all this information for researchers on how to, what is care and how to put in a request to use care as a referral source or a recruitment source. Please do check out our website, and we do have recordings from previous meetings. We are likely to schedule one in the coming months as well. We also created an ambassador program, and it's an opportunity to leverage the youth community to help us in improving ANHPI representation. And so if you or someone you know, or you would like to help share this opportunity with others, please do so. Eligible candidates are those who are high school or college students and really interested in learning about care and how to make a difference. So as I mentioned, CARE 2.0 was recently funded last month, and our goals are to expand the registry in the U.S. and emphasize or do some targeted recruitment among the underrepresented groups in our registry, including Asian Indians and Filipinos, Japanese, Native Hawaiians, Samoans, etc. We will also examine and develop methods to improve registry retention. So we hope to really contribute meaningfully to retention science, which is part of, the whole umbrella of recruitment science. And we want to optimize care registry participants' inclusion in ADRD, aging, and caregiving research, and examine the factors associated with research enrollment decisions by registry participants. So their research attitudes and their willingness to participate in various types of research studies. Now I'd like to transition to the Asian Cohort for Alzheimer's Disease Study, or ACAD. Many of you have probably heard of the ACAD study. We had a R56 pilot study, and we recently received funding in July for a U19. We have multiple principal investigators. Lisan's Wong is at UPenn, and myself, I am an MPI focused on the outreach component, or the outreach core for ACAD. The ACAD is the first AD cohort study focused on Asian American and Asian Canadian or ASAC older adults. And our goal is to develop more reliable AD diagnostics, including biomarkers for better treatments and health delivery for ASAC populations affected with AD. As of September 2023, or this month, more than 2,000 ASAC older adults expressed interest in ACAD. Among the 815 who have already consented to participate in ACAD, most 729 or 720 have begun or have already completed their participation in the study. Similar to CARE, we engage multiple populations, and namely for ACAD, Chinese, Korean, and Vietnamese. We do use CBPR principles as well. And we conduct a very thorough translation, or we engage in a very thorough translation process using the WHO translation framework for all our study materials as well as outreach materials. One thing I do want to mention is that using Google Translate is not the convention or the recommended way to do translations. Also, I do get asked the question a lot about the use of professional translations and services, and I will have to say that most of the time those are not very effective because they don't. There are a lot of considerations that must be factored in, including what is important or what is understandable to the target audience, taking into consideration potential political and regional differences as well. So here's just some examples, and I encourage you to visit the ACAD website to see, and CARE website to see the animated videos as well as the multilingual websites and other materials. Here are examples of our multilingual e-cards that we also send to our participants for both ACAD and CARE. And here are, I think, lessons learned. I've mentioned some of this already, but translations do take a lot of time and effort, and we need to also consult with our community partners and community advisory board. Education and outreach go hand in hand. So you can't just go out there and say, oh, enroll in this study. No, we have to give back to the community. We have to provide educational topics and presentations that are important to the community, and of course related to the work we do, but we need to listen to our community partners and make sure we show up and deliver. Also important is that we have to be able to adapt to our target populations and or the communities we want to engage with. You know, in some communities, for example, they have limited access to digital technology, or, you know, they're not very proficient with the use of digital technology. And, you know, they may also have transportation difficulties. And so we need to just be ready to adapt, be innovative, and provide other ways to help ensure their participation in research. So the VIP, Vietnamese Insights into Aging program, Wayne Meyer at UC Davis is the PI, and I'm a site PI for the VIP. It is a very important study because Vietnamese Americans have large or significant health disparities. Especially older adults, many of whom are refugees and experience a lot of trauma in their life. And so VIP aims to better understand the role of these experiences and how they impact thinking and memory in the Vietnamese American community. Our goal is to recruit 540 total, 270 at each site, and have 3 visits annually, one visit annually, I mean, over 3+ years on their memory, life experience, and medical history. VIP was launched in October 2021, and we achieved so far 90% of our enrollment target. So we are very close to the finish line. And this is really the result of extremely great community partnerships and dedicated staff. Apologize for going fast. I realize I don't have much time left. Kimchi is a Picori sponsored community engagement award, and we have community partners from the Korean American community and Haewon Shin, who is the executive director of Soming Society, and Eun Jung Lee, who is the executive director of AARIN. The purpose of kimchi is to culturally tailor the dissemination messages and health education surrounding topics like dementia caregiving and advanced directives in Korean, but also using terminology that are culturally appropriate and acceptable as well. If you would like to learn more, please do visit our kimchi website. I'm going to skip through this. Our Family Journey is a culturally tailored, evidence-based psychoeducational program for Vietnamese dementia caregivers. And this was funded by the Alzheimer Association. And we culturally, linguistically tailored Dr. Dolores Gallagher Thompson's caregiver program for the Vietnamese American community, who at that time did not have any resources available to them in regards to caregiving programs other than the minimal resources you find for educational materials that are found on, for example, the Alzheimer Association website. And what we found was that the program was quote unquote successful in various measures. And there's just a lot of work that can and should be done with and for the Vietnamese community. I invite you to look at the research papers on this project. And again, I apologize due to time constraints. I can't go in too much into the detail, but this is very important work. Just briefly, Arise is a recently funded R56 project, funded last week, got the NOA, and we're going to look at multi-level racism and discrimination experiences among older Asian Americans and the role of that with cognitive performance and levels of AD biomarkers. We're also going to look at resilience resources and how that is associated with cognitive performance and AD biomarkers as well. If you would like to know more about Arise, please do feel free to reach out. I really want to thank the staff and team from all these various studies, and I also really want to thank the funders, including the NIH, PCORI, and Alzheimer Association. And I again want to thank the conference organizers for inviting me to talk a little bit about the meaningful work that myself and others have been engaging in to improve research representation for Asian Americans, Native Hawaiians, and Pacific Islanders. Thank you very much.